Hello, everyone. Thank you so much for joining us today in our webinar. My name is Dr. Annie Rutter, and I'm the Academic Vice Chair and Director of Medical Student Education at Albany Medical College in Albany, New York. For the last several years, I've had the pleasure of working with the STFM-led Preceptor Expansion Initiative, working to increase not only the number, but the quality of our community-based education for medical students and physician assistant students and other health professionals. We're lucky this afternoon to be joined by many different members of multiple state chapters who can help us learn a little bit about tax incentives for precepting, how they work, and are they making a difference in their states. A few housekeeping things. We will have about 5 minutes for each state to present. Currently, there are 6 states across the country that are having these tax incentives. 5 of them are represented here today. Each group will have about 5 minutes to present. We'll then have an opportunity for a discussion and question and answer. So if you'd like to pose some questions for the panelists, please note them in the question and answer session. Also, if you have any information you'd like to share, not only with the panelists, but with all the attendees on today's webinar, you can use the chat, but be sure to make sure the drop-down menu says all panelists and all attendees in order for everyone to be able to share in their wisdom. So without further ado, I'd like to introduce Ryan Biehle, who is the Executive Vice President and CEO of the Colorado Academy of Family Physicians.
Thank you, Dr. Rutter, and hello, everybody. Good morning or good afternoon, wherever you are. I am in Colorado, and so it's 11 o'clock here. So looking forward to having this fun conversation with you. So we can go ahead and scroll forward in the slideshow here. I just wanted to show up front that I have no conflicts of interest to disclose in this. In Colorado, we had several goals in setting up our preceptor tax credit. And if we could advance the slide, I think 2 more times, I'll just go ahead and get those goals all the way up there for you all to look at. We in Colorado have a physician shortage in general, and particularly in rural areas. So that is probably not surprising to any of those on this call today. But essentially, we wanted to solve this problem or contribute to resolution of this problem. And we had 3 kind of main goals when we came to the state legislature to try to support our rural physicians and getting students into the rural physician pipeline. One was supporting rural medicine. So, the shortage of rural primary care physicians needs solving. So we felt that we could bring this solution forward, and legislators would be inclined to support getting folks into their communities to support their patients and take care of their patients. The other was to maintain and increase rural preceptors. So many of you may know that the training often falls to those who have been doing it for many years because of their love for family medicine or other primary care specialties. And we also wanted to recruit new folks into precepting. So it was really looking at this as both a recruitment and a retention tool. Third, we wanted to increase students' rural exposure. We know that students who are exposed to rural medicine are more likely to end up practicing in rural areas. And so getting more students into these communities throughout Colorado was a key goal of ours. And we actually have more students in the state wanting to rotate in a rural area than we had preceptors to take them. So we certainly have a shortage of kind of teachers out in rural communities. So this was an attempt to resolve that issue as well. So of course, we're developing the pipeline of rural physicians and kind of creating that continuity in their experience in rural areas throughout Colorado. So these are the 3 goals that we came to the legislature with, and we can go to the next slide and I'll tell you about how that went. We tried in 2015 to pass this and it failed. So for those of you looking to stand up a tax credit in your state, do not be dissuaded by hardship or barriers to getting it done. We came back in 2016 and were able to pass a bill that created the Rural and Frontier Healthcare Preceptor Tax Credit. We ran into a few different issues that hopefully we can inform you about so that you can avoid them. One, we had to explain what a preceptor is. I always joked with legislators that sounded a bit like Hogwarts or something like that. It's kind of this different world that they're not so familiar with. But essentially, we described it as a mentorship or an internship for students. We in Colorado created a $1,000 tax credit, and that is available for precepting students, not residents. And folks had to precept for a total of 4 weeks. This definition of a week was controversial, and we ended up having to come back to the legislature a couple of times to actually define that, enabling multiple preceptorships to count toward the 4 weeks, and eventually defining that as 20 business days or 4 working weeks. Unfortunately, that hindered our early implementation, and so that stalled probably the promotion of our tax credit for a year or so. We were still able to promote it, but it was confusing to folks, and that probably hindered how quickly we were able to get folks signed up for preceptors and into the program. And then we have to authorize the tax credit every 3 years. So that creates a lot of accountability for us, both good and bad. It requires us to go back to the legislature pretty frequently. So let's go to the next slide, and I'll tell you a little bit about the results that we're seeing so far from surveys. We don't have any formal way of tracking the effect of the tax credit. We have only had a couple of years of data, and that data came through an audit of the program. We found that in 2017, its first year, we had 76 preceptors taking it, and in 2018, we had 89 preceptors. So that was good. A trend over 2 years of increasing utilization of the tax credit. Our hope would be in the next year or so to be able to get additional data to see whether or not that credit is actually increasing the number of preceptors out there and the number of students being precepted. In lieu of that, we worked with our Colorado Rural Health Center and the schools of medicine and physician assistance programs and nurse practitioner programs in the state to survey those who had participated as preceptors. And we found 540 students had been precepted from preceptors in the program. We had a whole total of 178, utilizers of the tax credit throughout that time. 93% of preceptors reported that the credit made it more likely they would precept in the future. So it was a nice token of appreciation, if not fully compensating them for their time, because they did report spending about 1 hour per day teaching. But we're trying to provide data to the state legislature to indicate that this is an effective program and actually achieving its purpose. And finally, before I hand it over here, we had 38% reporting that they've previously hired someone who rotated with their practice. So trying to make that connection between students rotating in a practice or in a rural area and then later coming back there to provide care for patients in the future. So we're gathering this data. We'll continue to gather this data, but so far, I think the credit has been well received and appreciated by those precepting, and I look forward to more conversation here, but I'll turn it over to our other chapters.
Great. Thank you, Ryan. This is really helpful, and we appreciate you kicking us off today. We'll now move to Becky Wimmer with the Maryland Academy of Family Physicians.
Hi, first, thanks for having me. I appreciate the opportunity to share Maryland's tax credit incentive with you all. To help us achieve our strategic goal of an adequate family medicine workforce, we decided one project was to propose an income tax credit for preceptors in areas with healthcare workforce shortages in our state. Our original bill, which we authored, and borrowing and taking some lessons learned from our friends in Georgia, ended up passing in 2016, and the final version offered the tax credit to physicians and nurse practitioners who served as preceptors without compensation and worked at least 3 rotations, with each rotation consisting of 160 hours of community-based clinical training, as well as an area identified as having a healthcare workforce shortage, which is many parts of the state of Maryland. These physicians also had to precept in a preceptorship program that was approved by the Maryland Department of Health, and the credit certificate for $1,000 for each eligible student rotation was not to exceed $10,000 per applicant. Just of note, the funds for NPs come from a different source. NPs get their tax credit program money from an NP preceptor tax credit fund that comes from the State Board of Nursing licensing fees, which is of which there's a $15 assessment. And the physician's tax credit funds come from the budgeted Maryland Department of Health general funds. And the statute does indicate that this tax incentive is available only to primary care. The program was set to expire this year on June 30th, so we advocated for an extension, and it was brought up again during this year's legislative session. The new bill passed at the end of the session in April and extended a revised version of the program to June 30th of 2026. So we were pretty happy that they extended it a little bit longer this time. This bill also established a physician assistant preceptor income tax credit this time around, and similar to the physicians and NPs in terms of amount and number of hours. The credit dollar amount remains the same this time. However, the rotation hours decreased from 160 to 100 hours. And with the addition of the physician assistant eligibility for this incentive, those dollars come from special fund revenues for the PAs. So basically the funds are not shared between the groups of physicians, NPs, and PAs, but rather each has their own funding source. Each year, the Department of Health may issue up to $100,000 in physician preceptor credits as needed. And if the aggregate amount of the tax credit certificates issued in a year is less than $100,000, that excess amount may be issued in the next taxable year. And in addition, up to $100,000 in unspent health personnel shortage incentive grants funds may be transferred or reverted to the general fund to help offset any costs of the physician tax credit. Next slide. So what effect it's had on Maryland so far, we're still kind of early in the reporting process, but 2019 reports were recently released, and in tax year 2019, the department approved 34 applications total, and they awarded a total of $149,000 in tax credits, 68,000 of which was awarded to physicians and 81 was awarded to NPs. The full available amount was not utilized, and the 2020 reports won't be released until early next year, so we'll be watching that. There is some anticipation that the pandemic will impact 2020 numbers due to the shutdown in Maryland, and then afterwards there were lots of restrictions on allowing students once things opened back up. We had a little trouble getting specific data from the state, specifically the number of family physicians who are participating versus peds or others who are applying for the tax credit, but we surveyed our members, and out of about 100 respondents, 55% did precept before the tax credit was available, and 12% took more students as a result of the tax credit. We don't have numbers yet on how many students are staying in Maryland to train or practice, but we're working on that. 75% indicated that the credit doesn't influence their decision to precept. It's a passion they have, and they want to, they would do it regardless. And some members had indicated originally they weren't able to meet the 160-hour requirement in some cases, so the 100-hour minimum will allow them to achieve the credit in 2021. Several members also indicated they didn't know about the tax credit, but now that they do, they'll be seeking the tax credit, and that kind of prompted us to work on promoting it a little bit more than we have been doing, and we're working on an awareness campaign so some members can take advantage of this program. I'll stop here and happy to answer questions at the end with everyone else and pass it on to the next.
Great, thank you so much, Becky. And so now we'll move to Georgia with Faye Fulton.
Thank you, Dr. Rutter. And I'd like to also echo my colleagues in appreciation for STFM pulling together this important presentation. I think as we are going through the states, you begin to hear some similarities, and we're going to kind of tease out a few differences between Georgia and some of the other chapters, state programs. The bit of bragging that I have to start with is that Georgia was the first to create a tax deduction for preceptors in 2014. The reason we started it as a deduction is frankly because the Georgia General Assembly thought physicians are all rich and didn't need any type of tax incentive, and that this should be part of the career that comes with training the next generation of medical students. So after the deduction got up and rolling, we were able to reinforce the message about how a tax credit would actually be so much more of an incentive to get other clinicians on board and helping with the preceptor issue. I think it's also important to mention that in Georgia, we have a tremendous amount of medical students outside the state of Georgia, especially international medical students who are doing rotations in Georgia, and they are being paid. The preceptors are being paid to do those rotations. And the medical schools themselves in Georgia just couldn't compete with that type of outside funding. So this was another incentive to help, as so many of our medical schools have doubled, if not tripled in size over the last 10 years. And I'd also like to mention that annually physicians can receive a total of $8,500 in tax credits. The other part in terms of the secret sauce for legislative approval, and I kind of want to toss this out as a challenge for many of you who are thinking that maybe this year or next year, the following year might be a good time to jump in on this discussion. Timing is everything, and this is an excellent year for you to approach some of your more sympathetic legislators, especially those that represent your rural communities, because there is a lot of federal funding floating around down into the states related to COVID support. So that money will go away and it must be spent. So this is not a bad time for you to approach some of these budget decisions within your state. The special sauce in Georgia also was we immediately grouped together, not just with our other primary care physicians, but the medical schools and the PA and nurse practitioner programs. It was so important for us to bring it in so it wasn't a scope of battle issue. It was actually clinicians coming together, acknowledging that we just need more clinicians at a higher level of learning to serve all of Georgia. And that really helped getting the nurses and a united front for this request. And the next slide brings you to some of the data that we have accumulated. And again, speaking of the secret sauce, there's lots and lots of resources of how Georgia put this together at the URL that is listed here. The host organization, medical school, is really the Medical College of Georgia. Augusta University really houses all the information for the preceptors. I was kind of surprised, maybe those of you who are members of STFM might not be surprised, but I was really astonished by these recently updated numbers to see that we actually increased the number of preceptors in the middle of COVID versus in 2019. And that while we can't say that it has yet established more of our medical students in Masters of Nursing and physician assistance programs to stay in Georgia, that's what we're linking it to. And that's what we are planning on continuing to sell it. Much like the other states, it does have a sunshine. We do have to prove that it's working every 6 years. And we think we already have enough data to make that happen. And then our last slide, I think it's important to note, and many of you already do this, but to have a standardized training for preceptors to kind of take away the concern of community preceptors that they're not quite sure what they should or should not be doing. So I think that's important to bolster that. And then the other piece of the puzzle is that 62% of the credits have been earned and awarded for MD-DO support. And with that, I will toss it to our next presenter in Hawaii. Thank you so much.
Great, thank you, Faye. We appreciate Georgia leading the way on this one. So now we'll move over to Dr. Kelley Withy from the University of Hawaii Medical School, who is professor there and also the director of their AHEC. Thank you, Dr. Withy.
Aloha, and I'm glad I went after Georgia because, to tell you the truth, we just copied Georgia. Okay, presentation over. But seriously, So back to that other slide for a second. I actually can't take a whole lot of credit. Laura Reichart is a nurse practitioner, the director of the Center for Nursing, and she's a good friend. And she came to me one day and she said, have you heard about preceptor tax credit? Would you mind if we put it through the legislature? And I'm like, sure. And I thought she wouldn't get it through the first year. So I said, whatever you want. But now I regret that, because every New Year's Eve for the last 2 years, we've been going through the list and working on it till late hours. So go ahead to the next slide. So in 2018, it passed the legislature. As I said, in the first attempt, it was all her. And so we started in 2019. So we don't have a PA school. Well, we do now, but we didn't at that time have a PA school. So it was the 3 professions that well, it was first just APRN and medicine, and we have a DO branch, but then pharmacy got on board because we have a strong pharmacy school. So the 3 professions right now are APRN, pharmacy, and MDDO. We do include residents, so that made people happy. We have $1,000 per student, maximum $5,000 a year. So it's only 80 hours that counts as 1 credit, and that was a nurse practitioner thing because that's their rotation time. And so you heard the 100 hours credit. We do the 80 hours credit, which was strange to me, but there you have it. So if you take 5 students and you total up to 80 hours times 5, you get the 5 credits, even if 1 student is only 2 hours. So they do clinical skills with you. So it's an interesting setup. We were very lucky to get 1.5 million allocated to this. We've only spent about 400,000 a year, both years. We have to go back in 2 years and justify it, and they may change things up, of course. Any preceptor is compensated with blocked appointment time, or money does not qualify, similar to what you've heard. But this has been a bone of contention if they get time off for precepting. Primary care, we had to define very carefully, and now people want it opened up to anybody who trains future primary care providers. You heard the in-state, out-of-state difference. We only do in-state. It's a state-funded program, so we only do in-state training. And inpatient, outpatient has been an interesting challenge to us, because some of our primary care doctors are inpatient. They want to count that time, but we've kept it to outpatient. Next slide, please. So we have done about, let's see. So this is who we've done in the 2 years that we've had it. And you can see MDs and DOs were 79% the first year, 75% the second year. We did have a little decline with COVID, but it stayed about the same. When I went back and looked at the numbers, what we've done so far has recruited 68 new preceptors to sign up. Of those, 32 qualified. So we have 32 new preceptors in Hawaii because of this. One of those preceptors took 5 students at least, and 2 of them took 4 students. So they're productive preceptors. Next slide, please. Oh, there's our numbers. Okay, so in the 2019, it was 371, and then it was 368 in 2020. All right, next slide. Okay, so what did we learn? You've heard much of this before. Everybody wants in. We tried to get anybody else in schools-wise, we have to go back to the legislature. We have tried to go back to the legislature to actually expand the definition or clarify the definition of compensation and clarify the definition of primary care. But it didn't work this year, this most recent year, because they were worried that by changing anything in the tax incentive area, they would disqualify for any federal COVID funding, ironically. So anyway, we're going back this year to do that. Getting the departments to enter their data was the most cumbersome thing. That's what I said about New Year's Eve. We're checking everything over, but we really have to get on all our departments to enter data. Let's see, be very clear, very public. There's our website. You can see all our resources, and they look a lot like Georgia's. I want to thank Colorado as well, as Georgia. What is compensation and what is primary care? Things we had to define, and then we have to do regular updates and check-ins. So go ahead to the next slide. I'm not going to go into great detail on these because this is about how we got it through the legislature, but we're happy to help whatever state would be going through this. Georgia, Maryland, Colorado, we met with all of them online and talked with them about what they did. We asked different, partners if they're struggling to find teachers. We call the preceptors teachers. That's how we got it across, because what Ryan said was very true. People don't understand what a preceptor is. What is it? What is that? Why do you need that? So transparency, and then we had no data. So we helped develop, we had to survey, what is your need? What is your demand? What is your need and how many do you have? Next slide. And I just want to emphasize key legislators and be willing to bargain, and ask your tax office how this goes, because we copied, actually the forms we used copied the one of the other programs that exists in the state. Next slide. Yeah, no one knows what a preceptor is, so you got to define that. And next slide. And everybody, as I said, all the professions wanted in. We actually wanted social work in, but we lost them. And one conflict we've had is that the employers actually want the money to go to them. We said, no, it goes to the individual. And then there was the out-of-state students question too. Next slide, I believe, is the last. And when we crafted our message, we said how much a physician brings in a state. And because that exists, and then we had a united voice, the dire consequences of not having this. And actually we had primed the pump already, because research from my office shows that we are short 1,000 physicians in Hawaii compared to a continental community our size. So they knew there was a problem. And then we were very responsive to their requests. And I believe that's all I have.
Great, thank you so much, Dr. Withy. And with that, we'll move to our final presenter, Kathy Pabst from the Missouri Academy.
Thank you, Dr. Rutter. Our program, we've been working on it for 2 years. And as the last panelist today, we've heard from other states on their efforts in messaging. And Missouri has used the AAFP backgrounder and the Georgia legislation, kudos to Georgia again, as the basis as we crafted our legislation. We introduced it in 2020 and 2021, and spoiler alert, we're introducing it again in 2022. So we've learned a lot over the last couple of years. After the initial introduction in 2020, we learned that we needed to change the legislation title. In Missouri, tax credits is taboo, it's a bad word. So our old title was the Preceptor Tax Credit Program. Our new title is Healthcare Preceptor Workforce Program, which is more descriptive of what we're wanting to accomplish. We did define primary care as family medicine, internal medicine, OB-GYN, pediatrics, and then psychiatry was added in 2021. And our original attempt was to focus on rural areas. However, our legislators did not support that. They preferred to remove it. So we didn't have an issue with it because we also have underserved areas. And since most of Missouri is underserved, it really encompassed rural as well. We identified providers. We work with a group called the Missouri Healthcare Workforce Coalition. It encompasses medical schools, residencies, nursing schools, PA schools, state boards, hospitals, and other healthcare organizations. And the program is for medical students and physician assistant students. It was offered to nurse practitioner students. However, they declined because they already have a fee on their license that they use for recruitment and retention of nurses. Our tax credit amount is $1,000 per 120 hours of preceptorship, and that could be with multiple students. And to be eligible, you cannot be compensated for your preceptorship from anyone else. It is not transferable to future or past taxes due, and the maximum a preceptor can receive is $3,000 per tax year. So that's basically 3 preceptorships. Funding source is always a big issue. If it comes out of general revenue, it is dead on arrival. So what we looked at is our goal is to offer 200 tax credits per year, and that would be $200,000. We analyzed the numbers of our physician and physician assistant licenses to determine how to collect that $200,000. So we are proposing a $7 per license fee increase for physicians and $3 for physician assistants. There's been no pushback or negativity on that funding process. There was discussion on administration. As with most states, our Department of Revenue collects money and disperses it. This program would be through the Department of Professional Registration, since it licenses fall in both physician and physician assistant licenses. And there is no sunset clause in our program. Next slide. So we did create 2 educational documents for our program, and we use the AAFP backgrounder as a template. So the document on the left is more specific to the legislation. The document on the right is a very brief infographic that we used to easily explain the program. You know, everyone has talked about communication, and that is key, and it was key for us as well. And the next slide. So one of the things that you really need to pass the legislation is champions. And for us, we had a representative who believes in this bill. She's going to introduce it again next year. And she's working with a senator to introduce it on the Senate side. So we'll be working it on both angles. We also had a member who was passionate about this issue. He rounded the troops and got them to testify both in person at the hearing and in writing. And both the medical schools and the PA programs were very supportive. There was no opposition to the bill. And then what was most impactful were these students. We had a medical student and a PA student talk about their experience with their preceptors. And it was phenomenal. And the legislators and the committees really paid attention to what they had to say. So as I said earlier, this wasn't enough to get us over the finish line, but we were 1 vote away in the Senate from the passage. During the last week of session, it passed the House. It was voted out of the Senate committee, and they added APRN scope of practice to the bill. Therefore, we did not support it after that point, but we had strategically added it to other bills that were moving and close to passage. So the political maneuvers went on during the last week of session, and on the last day, the Senate adjourned 4 hours early after filibustering on unrelated bills, and nothing else was done. So we did not get our final vote, but I think the communication and messaging this year was very good to lay the foundation for hopeful passage next year. And that's my presentation. If you have any questions, just let me know. Thank you.
Great. Excellent. Thank you all for presenting today and sharing with us the states across the country that are working on these tax incentives. I'd like to draw everyone's attention to some STFM resources that are available. So if you follow these links, which will be available not only through the webinar, but the webinar will be recorded and posted on the STFM website. It will be posted at the link all the way on the bottom of this slide. Also, each attendee will get an email with a link directly to the webinar. The slides from today's presentation will also be posted at the bottom. In addition to the information from today's webinar, there's general information for incentives for precepting that are outside of just tax credits, but other things that medical schools or state chapters can do related to incentivizing community teaching. And then in general, if you're interested in more information about STFM's preceptor expansion initiative, there's a lot of information, resources for teachers, for medical schools, for community-based physicians, as well as medical students found at the following links. So now I'll ask all our panelists to turn on their video so that we can have a great discussion. We have several discussions that have come in through the Q&A already. But I think the first question really talks about, was directed towards Ryan in Colorado, but if everyone could sort of talk about, what their sunset sort of situation was. So how often they have to revisit, what they have to do in order to be successful in those discussions. So Ryan, I'll start with you. You answered, quickly in the chat, but if you could just tell us a little bit about how your process works and moving forward.
Yeah, you bet. So our first reauthorization was in 2019, and we also have to reauthorize it again in 2022. I'd say the 3-year sunsets are really challenging from a policy standpoint. That was really a political reality that we were facing, and we did it to accommodate the legislature's interest in making sure the credit was doing what they wanted it to do. But from a program standpoint, it's really difficult to have that uncertainty. It's difficult to message around it. And then, you also can't see trends over time very quickly in this world of healthcare and the workforce pipeline, right? So we have had some challenges in terms of making the case for reauthorizing it. For instance, we weren't able to show outcomes really of, what number of new preceptors had come in or what number of new students had gone into rural medicine. Of course, we don't have that information yet. So that was a challenge. And then we also faced the argument around tax fairness and whether or not, providing a tax credit to physicians was the best use of tax dollars when they're already very high income earners. We made the case, of course, that rural patients are vastly underserved. And if we don't do something to get, physicians and other providers in those areas, then they're going to continue to be unserved. And that is also an equity issue. So those were the issues that we addressed in 2019 and will again in 2022.
Excellent. Others who have time limits or sunsets on their legislation that would like to comment on that?
We have the 5-year sunset on our first legislation, and that's going to be interesting because we'll see if we're back in any kind of economic shape when that comes up. But that's in 2 years.
Ours is 6 years. Georgia is 6 years, and it really has become the standard language for all tax credits. If you watch national politics at all, you see Georgia's name is in it a lot for a whole host of things. But credits for blueberry farmers, Delta jet fuel, this tends to get very hot toward the end of the session. So instead of these credits just going on in perpetuity, they started to put every group in 6 years. I think because we're already collecting the data that we'll have enough to keep saying this is a do good. This is not necessarily to keep the film industry in Georgia, although I'm sure that creates jobs, but we're really about the heart of the community to helping the underserved. So it is a drag to have to renew, but I think that's also an important part to get your reporting early on. And the other thing that we've mentioned, I think all of us lightly, but don't underestimate the power that your medical schools have at your at your general assemblies, your state houses, and in the governor's office. Typically, they have so much clout. They are wandering, at least in Georgia, the state halls, and they get a lot of money. They produce most of the high earners in your state. And if you get them to put it on the top of their priority legislative lifting, then you can just trail along behind them, because that is the other piece. Is we have Morehouse in Atlanta and the Medical College of Georgia, but when everyone collectively came together, including Emory, that it really sealed the deal that everybody was talking the same talk.
That's great.
And I agree with that, Faye, because in Missouri, we have both, we have 6 medical schools for family medicine, and both public and private. And coming together was key. And like I said, there was no one who opposed it. We did try to find out if any preceptors were paid. And this is not research-based, but we found that the preceptors from the public medical schools were less likely to be paid than those in the private.
Yeah, Great. Thank you, guys. Everyone mentioned sort of in passing the partnership with, or several of you mentioned the partnerships with your medical schools. Obviously, Dr. Withy with your connection with AHEC, but have others found partnerships that they found particularly helpful as they moved this through? So anybody who wants to take that one, I don't know, Dr. Withy, obviously your experience with AHEC, but is there anyone else you felt like was a key partner in your passage in Hawaii?
So we've reached out to our medical groups because we realize that they're very important. They actually have great lobbyists. So our larger medical groups, and they actually came on board. Our hospital association, although, you know, I said we don't do much in the hospital, they supported us. So we had nobody that was against us. It was just up against the money. And so that was nice because we had all supportive testimony. But any medical group or who else did we have? Nursing groups, the medical students, as you heard, you know, we had lots of testimony about how important it is, especially from the Rural Health Association was important too. So everybody supported it.
Other key partnerships that anyone wants to mention, or were there other groups that worked with AHEC? Faye.
I have a question to Dr. Withy. You said you were interested in bringing the social workers in, and that ultimately they didn't end up being a part of the coalition and receiving it. Why is that? Because especially maybe not so much then, but now with the drumbeat of how do we get mental health out to so many people who need it pre, during, and now post-COVID, why did the social workers walk? I would think that that would have been a natural grouping.
Yeah, they're not a very strong organized group. And I don't think they walked, actually. I think it was just, let's keep this primary care focused. I think that's what it was. So I'm not sure. In the workings of the grant, it took on some things. We have a AT Stills outpost here, and they came on board and they said, wait a minute, what about us? And so they got in, and I just don't think anybody spoke up so much for social work, even though we wanted them in. I think it just got lost or something. I don't know. So we want to revisit that.
Anyone else working with their AHECs? Yes. Yeah, Kathy. Ryan?
Yeah, I'd say our AHECs, our rural health office in Colorado, is central to this. And then the other usual suspects, the medical schools, we have two, and the nurses and the physician assistants, as well as the dentists in Colorado. It was a broad coalition.
And I will mention our Department of Health. So our Office of Primary Care and Rural Health is always instrumental. And what we've had to do is the money actually goes to the Department of Health, because if it goes to the university, it kind of gets lost. So we certify, and the Director of Health signs the forms and sends them to the we send them to the individual. So our Department of Health was key.
Great, thank you. So some mention of preceptor development. Are there any other specific programs that you're requiring your community-based faculty to participate in order to obtain the tax credits? Does anybody have any required faculty development? All right. So moving on to a couple other questions, and Faye, you answered this one already, but why don't we go through each state and talk about how the tracking or verification of preceptor hours happens? Dr. Withy, I think you've told us how you've spent some New Year's Eves recently, but Ryan, how about in Colorado? How is that tracked for you all in order for preceptors to receive that credit?
Yeah, it primarily has to go through certification through whatever the program is, whether or not that's the MD program, the DO program, or the PA, APRN. So they have to certify the preceptor as having participated as a preceptor with their program. That's essentially it. Otherwise, the accountability to the state is just an attestation by the preceptor themselves that they're eligible for the tax credit. So that's generally how we do it. And, you know, as I said, we had a lot of challenges in the beginning with the definition of a week and what that means. So, you know, to the extent that you can get clarity out of the gate with, you know, a certain number of hours that are eligible, you know, that makes a preceptor eligible, something like that, that would be really helpful, because we really stumbled on that one, I would say.
Becky, in Maryland, how is this done for tracking in your state?
Yeah, the Maryland Department of Health approves the preceptorship program, so an application has to go through them, and then they do the tracking, and the tax credit certificate comes from the Maryland Department of Health then as well, so that's all through them.
If I remember correctly, that's where the funding source is for the MDDO
Correct.
portion of the tax credit is through.
Correct, so it's all housed with them. Yes.
Yeah. Okay, excellent. Excellent. All right. Well, I would also like to just take a couple other questions. And so you all talked about a couple of different key partnerships specifically, but how did y'all get started? So many kind of looked at Georgia's process and kind of borrowed from that, but what were sort of the first steps in getting things moving in your state? So Kathy, you're the one kind of getting on board trying to get this passed through in Missouri. Why don't you tell us a little about that process?
Sure. So a member brought this to us, and we thought it was a great idea. And in Missouri, we have the Missouri Healthcare Workforce Coalition. And as I mentioned before, it's comprised of a variety of healthcare groups, schools, associations, residency programs. And this was one of their priority areas in their strategic plan. It also aligned with our strategic plan as far as improving the workforce. So I was chair of that working group. And as a result, we were able to pull in all of those players to work on the passage of the bill. And I'm sorry, I'm still heartbroken. It was so close. So we used this coalition as a tool, and it was one of their priority areas. And now we're trying to refocus on what we're going to be doing next. So
excellent. Faye, how did you all get started? Because you were the first one. So what were the first steps that your group took to participate in this?
The Georgia AHEC was really the focal point, and for years they have supported a primary care council that comes together at least quarterly, and we try and tackle some of the harder issues and look at a 3 to 5 year plan. And this seemed like a bit of low-hanging fruit in terms of find 1,800 more primary care physicians by 2020 was a little daunting, but starting with, hey, here's where we're losing people, we're losing ground with having to ship Georgia's medical students who will more than likely stay in Georgia, but not if they're doing rotations in other locations. So that's where it started, was actually a coalition that our Georgia AHEC has continued to support and lead.
Anyone else want to share their getting started experience?
I kind of shared mine. I think my colleague at the Center for Nursing went to a conference and heard about it and came back and said, can we do this? And I said, go for it, because I thought it wouldn't go through. And she's just amazing. So it went through.
Excellent. Ryan, how about you all in Colorado?
Yeah, I started at the Academy in 2015, so I inherited a little bit the initial bill. But really, I would say we just built our early momentum with kind of getting broad-based support from other professional groups, right? Not just the physician groups. And I think that was important because I think, Faye, everybody's really said it, that really this is about getting care into rural communities. So we just really started from there and tried to build more of a grassroots kind of broad-based coalition around it. And that's, I think, ultimately what made us successful.
Becky, anything different in Maryland for how this got started?
No, not anything really different than what was already said. That was a little bit before my time with the Maryland chapter as well. So I just, some of it is a legend, but yeah, we have lots of support, and we have lots of support in the legislature for primary care too, which always helps. Our session is pretty short, so we have to get things through. So having those champions in the legislature really helped.
Excellent, great. So many of you work for or work with your state chapters or work directly for your state chapters. Are there other programs that your state chapters have done in order to recruit and retain preceptors, or is it really just that your work with the tax credit is the most robust thing that you've done? Are there other efforts to help recruit or retain, Kathy?
In Missouri, we've offered CME sessions at our conferences, and we've also promoted it in our magazine with articles by preceptors to encourage others.
And this is Faye in Georgia. From time to time, and we get outreach directly from the different medical schools saying, we need more preceptors. Would you send a direct outreach within this geographic footprint? We're always happy to help connect them. I think sometimes a lot of it is a lack of what being a preceptor means and how that looks and what it looks like and how much time it is. I feel like once they've cracked the code with a little bit of guidance and direction, there are some videotapes on the Georgia AHAC PTIP website. Once they, because no offense to you family physicians on this call, but y'all like to do it perfectly. But once they get the first doctor or the first medical student in, then they're hooked and they're in it for life. And then the tax credit, tax deduction, then that's just really icing on the cake. So really it's luring in those community-based family physicians and other physicians who want to help with training. They're just not quite sure how.
Ironically, in Hawaii, we used to provide free malpractice and free library sources to our preceptors. We used to. And then, of course, things got more expensive and we weaned off on that. So then we tried preceptor events to reward them. We tie it into our loan repayment. We ask them to precept, but we really have inadequate reward for teaching, which is, we're all dependent on it. And so it really is amazing and essential that we provide something, however small this is.
Yeah, I think, you mentioned something that and STFM really found that was the case too. It just felt like there was a need for recruiting preceptors, not just numbers, but quality, making sure we have really good community-based preceptors, not perfect, right, Faye, but really strong precepting. And I think medical schools, I'm a clerkship director. I'm working to recruit preceptors and all the time and really struggle feeling like I don't have the adequate way to say thank you or not just incentivize, but really thank them for the work that they're doing, because so many, has been mentioned in other of the surveys, so many preceptors would do it anyway. They would do it because they're good people, they want to give back, but it feels inadequate to not have something major to say thank you for all of that. There was a question that came across. Faye, go ahead. Yeah.
I was just going to add, you're striking on something that many of us who work heavily in policy and advocacy, sometimes we miss the easiest part of this puzzle, which is, and Kathy talked about this, about her secret sauce, about bringing medical students in to talk to the legislators. Remember to thank them. Don't just give them a report with statistics, although we love statistics that show that this is working, but thanking the legislators and saying, you are a legislative champion because you're bringing so much more education to rural or underserved communities in Georgia. It's such an easy thing to do. And it's the easy thing to forget when you're already on to the next legislative agenda struggle, or you're looking for more money or more activities around that. So that's the other piece of the puzzle, is legislators, and who doesn't love to be thanked, whether they were part of the solution, they will take pride that they are now part of the solution.
It's a great insider tip there. I think there's another one that's mentioned here in the chat, workforce, using that word, that's a word that can really resonate with legislators. And there's data to back that up. So a recent ABFM resident graduate survey showed 19% of respondents saying they are currently practicing in an organization where they completed a clerkship or some other part of their training. And while that's not a huge number, it's not insignificant. That many of you are talking about recruiting students to then practice in states where you're all representing your members, but also in the rural parts of your state. So getting students out there is some retention in that effort and is worthwhile. I want to take this opportunity to also just invite anybody who's an attendee on today's webinar. You can write in the chat if you'd like your audio taken off to be able to share with us your state's experience. So the 5 states represented here: Hawaii, Colorado, Missouri, Georgia, and Maryland. South Carolina, we recently learned, has joined this elite group of states doing this. But if there are others that would like to chime in, just put your name in the chat, and through this webinar software, we can unmute you and you can share your experience. Dr. Withy, I saw that you unmuted. There's something you want to add?
Oh, yeah. So for a while, because the practice requirements got so much more intense, a lot of our community health centers stopped taking students. And now they're realizing that that was a way to help recruit, and they've kind of switched on that. But that's an important aspect to make clear. I mean, if it costs hundreds of thousands of dollars to recruit a physician, but you can have a student there, and yes, we heard it takes an hour a day. So how do you compensate that clinician for that hour a day? And that's what we're trying to do. So we actually had an interesting situation where one of our partners compensated them with 2 blocked patient spots every half day. And they were very upset when we said we couldn't give them the $1,000 also because they were already compensated. So we applauded them for doing that, but they were frustrated.
Yeah, there's a lot of, and we've heard this, you know, throughout everybody's presentation today. There's subtle differences between these programs, and there's definitely some lessons learned, sort of addressing the language, partnering with different strategic partners, figuring out whether bringing on other health professions makes sense, or in certain states where that doesn't make sense. You know, not latching on to the rural workforce, but also understanding there's other areas that are underserved. So, you know, Kathy mentioned in Missouri, it's not just about rural, but there are other underserved areas that, you know, legislatures and funding could really, really be used to make sure that those areas are also getting the care that they need, the physicians and other healthcare clinicians that they need. I want to thank all of our panelists today, and we'll put up our slide one more time just to make sure we share the resources with everyone. I think this has been a really amazing group of individuals who have not only presented for us today, but really made huge strides in things that are extremely tangible for preceptors, for community-based physicians, and then for medical students to be able to get these experiences. There's a really wonderful opportunity. All of the folks on this webinar today have agreed that you could reach out to them. We've all leaned on each other in these experiences. And so, you know, there is an opportunity to continue these questions and get these connections. And hopefully we'll be able to share some contact information with all of you so that, yes, we can, you know, keep this conversation going. There was a question earlier about an effort on a national level, and that has not been something that has been addressed. This is more on the state level, and so unfortunately, certain states that don't have, you know, income tax or other places may struggle with similar programs. But certainly, we will have an opportunity to continue this conversation and hope that these big efforts that really tangible ways to thank our preceptors are available. So I want to thank all of our panelists today. Thank you for taking the time to put together the information you've collected. And I'm hopeful that through STFM and other organizations, we can keep the conversation going, but also share the outcomes. I think we've got some early data in a few states. Certainly Georgia has some great data after a few years. And then, you know, we'll see more of you as you have to continue every few years to prove the worth of these programs. The data will be out there. And so again, if there's any final comments that anybody wants to make or things that we want to make sure we share with our group in our final minute here. Excellent. All right, well, thank you again to STFM for hosting this. I really appreciate everyone's effort for this. Thank you for joining us in the middle of the summer. This is an important topic to have such a great attendees. So thank you all and have a wonderful rest of your day.